All right, Dr. Naina, thank you again for hosting our Access Live. You are live, and you can begin when you're ready.
Okay, hello everyone. Obviously, I'm not being able to see everyone, right? So, we're doing I don't know if how many of you are familiar with bioidentical hormone replacement therapy. So I made this topic, being that it's only 30 minutes, to sort of have an overview without getting super technical on each aspect of the safety of bioidentical hormone replacement therapy. And I would be welcome to have any questions after the presentation if anyone wants to go more into detail. And I think Leo, also you were saying that we can certainly have some updates on bioidentical hormone replacement therapy webinars as well. But this is just the initial. And I think for those of you who are already doing it, I just think it's a great review because a lot of the clients are going to ask you, if this is safe. Many of them will be going to gynecologists who literally will say, oh my gosh, get off the hormones. They're going to cause you cancer. And this is something, a little bit of a conflict I usually have sometimes when the gynecologists in the allopathic fields, not the integrative fields, don't understand what bioidentical hormone replacement therapy is. So one of the things is that I think it's very important to realize as just a beginning is that there's a lot of crossover of key hormones, meaning depending on which pathways, enzymatic pathways, we can have a crossover. So for example, DHEA can, interconvert depending on the pathways to estrogen, believe it or not. And testosterone can aromatize it. It can go to estrogen. Progesterone can also go. So you can see that there's a lot of interplaying. There's through another pathway, you can have pregnenolone, progesterone going to cortisol even. So the reason I bring this slide is it's so important to recognize that we don't know what each individual's predilection is going to be for which pathway. So that's why there's such a variation on the reaction to certain hormones that we give. Some people only are going to need a very small dosing, where others might need a little bit more. And so, but this really explains why sometimes there's such a variation of that. So next slide I want to go to is just want to point out that there are really three types of estrogens. Right off the bat, I just want to get into that. And there are estrones, there's estradiol, and there's estriol. And there are many downline estrogens that we never check for in blood work. So most of the time we just check for estradiol. And that was based on, Dr. Spiroff. He was a godfather of gynecology. And he literally said, that it didn't matter what kind of estrogen came into your system, everything just gets converted to estradiol, and that's what the body is going to utilize. Well, that's not true. New England Journal of Medicine back in 1990 had many articles on the different kinds of estrogens. So there's more than 20 downline estrogens, and E1 is generally regarded as estrones, E2 is estradiol, and E3 is estriol. In bioidentical hormone replacement therapy, it is the estriol, which is the most it's the most bioidentical to the hormones in our body. And yes, we also have estradiol, but estriol is extremely safe. And as the presentation goes, I'll explain to you why. But I just wanted to let you know that there are a lot of abstracts and there's also studies that have actually studied estriol. The reason this has never become popular is because it's been generally regarded as a sometimes weaker estrogen, but more importantly, pharma can't really make a drug out of it. It's kind of present in all generics. It's in, it can be in plant-based, in yams, in phytoestrogens. So it's really hard to kind of patent an estriol formulation. Again, I'm just not good because of the time constraints, but there's plenty of references where, they've looked at, the risks. There was actually the whole safety thing. If you're familiar with the WHO, the trials, the WHI trials, and the WHO trials, some of them estrogen alone, estrogen with progesterone. Some of these trials were stopped because of the thromboembolic risk and cardiovascular risk, and some even for the cancer risk. But these were really synthetic-based hormones. They were not bioidentical. And so there's a lot of articles that include, you know, that again, for estriol and how intravaginally, topically, even orally, how it is safe. It's a very safe estrogen. Going on to, let me see here. Again, a lot of our preparations, this is just a slide I just wanted to throw in there, that a lot of the critique in bioidentical hormone replacement therapy has been that, oh, you don't absorb any of the hormones through the creams. And just want to remind you that there was actually a pharma company that did an estradiol gel. So obviously hormones can be absorbed. Also, there's the OrthoEvra patch, which is a birth control patch. So we do know very biochemically, and it's a biochemical fact, that hormones certainly can be absorbed topically. And bioidentical hormones are really hormones that are identical to hormones produced endogenously, and the molecular there is identical to the to generally I say the estradiol and the estradiol. Now we have estrogens, but these are generally from the environment and exogenous, and the body really, as you will see later, really has to metabolize these estrogens to a much safer, namely estradiol, or if it can get to some of the good downline estrogens. So again, in the discussion, I think it's very important to recognize, again, Spearhoff, and in his book, always said progestins. Not all progestins are the same. There's progesterone, there's progestins, there's progestogen. All of these are certainly the medroxy progesterone acetate, oral micronized progesterone. All of these are very different. So if you look at the chemistry or the biochemistry or the chemical structure of each one of these progestins, they're definitely different. So it's very difficult to try to categorize them. And I think it's an error to try to categorize them all as one type of a progesterone. Progestins generally mimic the body's progesterone to find a progesterone receptor site, but they don't deliver the full range of the hormone message signals like the natural progesterones do. And there's a lot of synthetic progesterones which may have a similar effect on the endometrium, but they don't have an effect sometimes, or at least a different type of an effect on the brain, the mineralocorticoid receptors, etc. These different progestins have been mapped to affinity to androgen, progesterone, glucocorticoid, estrogen receptors. So again, this is simply just to say that not all progesterones are going to hit all of the progesterone receptors that the natural progesterones would hit. Same thing true of the estrogens, same thing true of the testosterone. There's sufficient evidence also to suggest that pulsatile delivery of estrogen and progesterone that occurs naturally enhances the function of these hormones in the body. I think it's very important to recognize, and this is why I put it under the safety of bioidentical. We as doctors like to sometimes just do one-time dosing because the client says it's too difficult to do, sometimes 2 to 3 times a day dosing. And so we try to put everything all at once, and we try to give a higher peak. And I don't recommend doing it that way. That's not how I've done it. I've done bioidentical hormone replacement therapy for 15 years. It's just by educating. It takes more time to educate the client and the patient. But once I educate them that how the pulsatile delivery is so important, my typical dosing regimens are usually, twice a day. In certain females, I sometimes dose 3 times a day. So I think it's very important to recognize that you want to maintain this pulsatile delivery. And when you create small pulses, and it's a much more synergistic effect when you look at the rest of the biochemistry of the patient. In theory, continuous application of hormones may downregulate the receptors, so there's a decreased activity of these hormones. And it's really important to note that when you have too much of a hormone and too little of a hormone, it kind of causes the same effect, because you either have the downregulation or you have receptors that are really starving for that hormone. So the effect is kind of the same. A reduced dosage would imply a decreased likelihood of unwanted side effects, as well as reduced impact on the liver due to their metabolism through the liver. So once again, I just recommend small pulsatile dosing throughout the day, and typically a BID to TID regimen. There's many different ways to take hormones. Certainly there's the oral, transdermal, percutaneous, which is the topical, intramuscular, sublingual, pellets, and nasal. And what I've found, I think the safest is the transdermal, the sub-Q. I think the pellets are great, but I used to do pellet therapy pretty much exclusively years ago. And when I started seeing that certain people, again, couldn't tolerate the sudden peak. If you inserted, for example, in a man, let's say 1,200 milligrams of testosterone, some of that still would aromatize. And the way you can easily prove it to yourselves and to your clients is to simply a week later check some of the common estrogens and see where that's happening. Check the DHT levels and the other metabolites of testosterone. Same thing with estrogen. Sometimes I would see women's blood pressures go up and I couldn't understand it. And it was because, and then it would again subside almost after 2 to 3 weeks of the pellet therapy. And so I do think that with pellet therapy, you do still get a sudden high, and then it sort of stabilizes throughout the subsequent weeks. But if people can tolerate that subsequent high, that's great. But I have seen TIAs, I've seen blood pressure issues. And so I approach that once again, with caution. And that's where I really recommend that don't think that just because you're using bioidentical hormones, it's just a safe thing. You need to be aware of these types of situations that can arise, and then have a alternative regimen for them. In terms of the dosing of percutaneous, which is really the topical versus the vaginal, obviously there's a greater circulating blood levels vaginally of the estrogens and progesterone. So intravaginal delivery is also common. Once again, the bases are really everything. Each pharmacy, I just need you to recognize, it's not going to be the same, even though they may say they use the same base, even though they may say that they use the same like PCCA or in a Veribase and so forth. It really is sometimes not the same. Pharmacy to pharmacy can differ, and patient to patient can differ. And what I'm getting at is that sometimes patients using hormones intravaginally, usually sometimes will say, how am I getting yeast infections? And it's these hormones are getting me yeast infections, because these hormones, along with the bases, depending on the variability of the client, it can change the flora, vaginal flora. So just need to be aware of that. So if you're getting, any issues that way, I still like the application, topical application. And I love using the inside of the wrist area. So there's another, again, these studies just simply show when you use synthetic progestins, it can definitely increase the risk of sometimes cancer, and sometimes even though it does definitely can help with the menopausal. So we really want to try to avoid any risk. And that's why I think going to bioidenticals, using them topically is a great way. And also sublingually is also a great way. In terms of estriol, which is my favorite estrogen, combined with a little bit of the estradiol, usually in an 80-20 or 90-10 preparation as a cream. Even I do that sometimes as sublingual drops. I think that estriol, we know, has demonstrated to reverse vaginal atrophy. A lot of people think it's only estradiol. And it's really interesting to know, and I want to get into this a little bit later. How many people do you know even understand that there's estrogen receptors? There's alpha and beta. And alpha receptors are located near the nucleus of the cell, and the beta receptors are located near the membrane of the cell. So it's really interesting to note that in the vaginal area, and especially in the urethral part of that area, you have more beta receptors than alpha receptors. So it's no wonder why estriol, which has the highest affinity for beta receptors, would work maybe even better than estradiol, which has a higher affinity for alpha receptors over the beta, especially when in that vaginal area, in the urethral area where you're using it for, there are more beta receptors. So if you do a search and just do some, research, there are beta receptors and alpha receptors distribution, which I've done separate talks on, just on that subject. And it's really interesting why estrase and estradiol is being used, when estriol works beautifully and it's so much safer. So estriol dosing is much higher, of course, but you can dose higher with it, but it's very safe. So you can achieve, similar, if not better effects to control the hot flashes and the vaginal dryness in menopausal women. Again, I like to typically dose estriol twice a day to achieve steady state. So what I might do is I might do a biased cream preparation in the morning and then tell them to use an intravaginal cream, in the evening of estriol. There's hemostatic effects of BioHRT, which really gets into, again, why it's even more safe, because we found that in studies that progesterone cream for safety and efficacy found no markers for inflammation or clotting. In fact, it really helped not increase the risk. So it's more of a benefit even on the homeostasis bioidentical hormone replacement therapy. Whereas if you look at methoxyprogesterone acetate, that's not true. So with the other progesterones, that's not true. And even in the PEPI trial, in postmenopausal women that were using estrogen progesterone, that this was the synthetic, they actually use a bioidentical progesterone, but they use it orally. So, and again, let me finish what this PEPI trial is, and I'll give you my opinion on oral use of bioidentical progesterone. So this was oral micronized progesterone. It did not negate the beneficial effect of estrogen on the HDL. And then I want to mention that this is the third generation progestins, such as the norgestin and desogestrel, have not demonstrated the same adverse effects on lipids like methoxyprogesterone acetate. It's more in line with the oral micronized progesterones. So yes, third generation progestins can also have a benefit on the lipid profile. It's not that every synthetic progesterone is going to have a negative effect on the lipids. Methoxyprogesterones increase the severity of atherosclerosis, but the oral micronized progesterone does not. So it's just, again, pointing to the fact that, we really have to define what progesterone that we're using. And even the bioidentical progesterone can have a very benefit effect on hemostasis and on the lipid profiles. It even has a good effect on the thromboembolic prevention. Basically, if you take the conventional estrogen replacement therapy, it's known to increase the risk of blood clots. And the whole idea of that is you've got circulating estrogens and they're going and activating the clotting factors. And sometimes the high dose of the estrogens and oral estrogens, they increase the liver protein synthesis, including the coagulation factors. But oral estrogens also are known to increase angiotensin, which can increase the blood pressure and stroke risk in susceptible women. Oral estrogens can also activate clotting factors in the liver. So randomized crossover studies of estriol, it did not affect the hemostatic function. So whereas the ethinyl estradiol, more of the synthetic estrogens did, affect it. So once again, using bioidentical hormones is more benefit than risk. There's also blood pressure effects, again, of a BioHRT. Synthetic BioHRT with estrogen certainly can, cause hypertension. But the anti-mineral activity of bioidentical progesterone, it antagonizes aldosterone. So you have an increased urinary sodium excretion, which may actually reduce blood pressure in hypertensive patients. It's a very common thing in my blood pressure clients. That when I administer bioidentical hormone replacement therapy, a lot of times the blood pressure will come down, the cholesterol starts coming down. So there's many benefits when you use the right amount and the right kind of, and the right delivery method of bioidentical hormones. Normotensive patients, let me go here. Normotensive patients, the bioidentical progesterone can decrease vascular sympathetic tone without any concomitant drop in the blood pressure. Bioidentical progesterone, it acts via the nitric oxide pathway, and that's again something that not necessarily methoxyprogesterone, acetate, and other synthetic progesterones do. So it can enhance therefore vasodilation and improve the microcirculation. There was actually a large cohort study because again, the effect of BioHRT on the breast. This is the biggest thing because a lot of the gynecologists, my clients will say, my gynecologist said not to do bioidentical hormones, Dr. Naina, what do I do? And, you know, I think it's just an education thing and recognizing the different types of estrogens once again, and not categorizing them all as estradiol. But there was a large French cohort study and it said 1,150 women with benign breast disease showed no increase in breast cancer risk with women using topical progesterone cream, which was really a common treatment for breast pain. In addition, researchers noted a decrease in breast cancer risk in women using progesterone cream plus oral progesterone compared with women using just the progesterones alone. With respects to estrogens and breast cancer, the most important consideration is the susceptibility for abnormal estrogen metabolism due to liver biotransformation dysfunctions. And by that, I mean is that if you have, and I'll go on to explain, it's so much of estrogen is based on estrogen metabolism, and that involves a phase 1 and the phase 2 detoxification system, liver, in the pathways in the liver. And there's particular enzymes which are responsible, for example, detoxifying the estrogens. For example, hydroxylating and methylation is extremely important in order to get rid of the estrogens. So if you have people that have impaired methylation, or if you have people that might have genomic SNP, single nucleotide polymorphisms for the CYB1 or the COMT, SNP, these people might be more susceptible. And it's very important to recognize that it's really not the bioidentical hormone, but it's the biochemistry of that individual. So this leads us into the discussion, of course, of the liver detoxification pathways, and the emphasizes in the importance of individual variation and the biochemical differences. So just be aware of that. That's why I think it's so important, to get your history in terms of the importance of testosterone replacement therapy and the importance of the androgens DHEA, we know that testosterone is one of the few anabolic hormones that we have. So yes, sarcopenia being the #1 biomarker of aging, absolutely testosterone is important. And so recognizing that, that testosterone replacement therapy can, instead of synthetic, you can also get phytoestrogens. So bioidentical testosterone or through the creams can be a very beneficial thing. The creams do tend to can aromatize, but it allows me in my 15 years of doing this, I am able to minimize the use of estrogen or even biased, which is the bioidentical hormones, the estriol, and by counting on that fact that I can get some aromatization with the testosterone. So very commonly, I will try to maximize testosterone without any of the untoward side effects, still keeping it within the low dose physiological range. We're not overdosing. So all of those things that people hear about, clitoral enlargement, acne, loss of hair, all this stuff, that's when you're overdosing somebody on testosterone. And the whole idea in bioidentical hormone replacement therapy is to do physiological, pulsatile, low dose bioidentical hormone replacement therapy. And again, we know the importance of DHEA, especially in terms of the adrenal gland. As the adrenal gland, as we age, especially in women, the outer zone of the DHEA, it can also start producing estrogens, and those estrogens do have to be, metabolized into the estradiol. And so that becomes a very important aspect, and this hormone does decrease the DHEA. DHEA is also a very anti-inflammatory hormone. If you start to, I've had people with interleukin-6, especially believe it or not, during the COVID, interleukin-6 marker went up quite dramatically, and I used DHEA, and I was able to, in 4 to 6 weeks, retest the interleukin-6 levels, and you see a beautiful correlation of that coming down as well. So I think DHEA is a fabulous anti-inflammatory hormone as well. Of course, there's importance of other hormones to keep your cortisol levels balanced: insulin, melatonin, growth hormone, and thyroid. And there's many others. We're finding in weight loss, the leptin, the ghrelin, and many other. I'm just mentioning a few for the sake of the limitation on the presentation today. I think the treatment goal in bioidentical hormone replacement therapy is that we really need to, minimize the dosing of the bioidentical dosing of the bioidentical HRT by optimizing estrogen metabolism and balancing any existing system imbalances in terms of functional medicine approach. So I think this slide is so important, because everybody just thinks that the vertical is a bioidentical hormones. And I get so many clients that have been to other physicians because they were doing the vertical of just prescribing the hormones, when it's really the biochemistry where you have to look for thyroid dysfunction, adrenal dysfunction, neurotransmitter imbalances, gastrointestinal imbalances. Gastrointestinal imbalances, if you don't have the right beta-glucuronidation activity, you're not going to be able to excrete the estrogens that you just, because they require glucuronidation in order to be metabolized out of the body. So it goes on and on. Mitochondrial dysfunction, inflammation reduction, immune system imbalances, environmental toxin exposure. We're inundated, with toxin exposure of xenoestrogens. And PCOS is out of control. It's an epidemic proportions these days. Diet regimens, exercise regimens. So this is the most important slide I think you can think in terms of really prescribing bioidentical hormone replacement therapy. You really minimize the use of the hormones when you do this. It's very important to get the patient history as it relates to estrogen metabolism. I just want to go back again, touch on that. The metabolism, it all has to do with, if you've had a history, if the client has had a history of, for example, excessive antibiotic use, they're going to have they may have a dysfunction of the, or an overgrowth of certain bacteria, which is going to affect the beta-glucuronidation activity. They're also going to have the gall system affected, which is the the gut lymphoid, the gut-associated lymphoid tissue, which is responsible for the immune system. So it goes on and on. You have, plastic exposure, pesticide exposure. What is your diet? What are you getting in terms of PCBs and all those kind of things? And the list goes on and on. It's really getting a good history of their possible exposure to xenoestrogens that you cannot control. So I just start using added insurance to my hormone replacement therapy, because I know that the way I'm giving the hormones is not going to cause the cancer, but what's going to cause their cancer is going to be these xenoestrogens and maybe their diet and lifestyle. So I need to start to use nutrigenomic factors to optimize their estrogen metabolism. So, and I'll touch on that a little bit later. Again, I'm going to get into the more of the estrogen metabolism. There is some practical laboratory testing that I think, in addition to the hormone, I like to use the hormone saliva test, and I'll explain why I like that, or the blood. I still use a blood as another key point of data. There's no harm getting both, but you have to recognize that if a woman these days, if women are getting imbalances much earlier on at age 35, they may be on the pill. A lot of women are also on the pill that doesn't even give them a period. So if you check levels, hormone levels, they're going to read low because they're already on the pill, or they're on some sort of a hormone orally. So it's not going to really give you an accurate picture. So then how are you going to be able to navigate that? How do you still determine that they might be low progesterone and they're stressed out and having severe dysmenorrhea, and maybe it's a low progesterone situation? How do you know that the woman that's presenting with PCOS that's just got on the pill, it's really actually estrogen dominant state that you have to fix first? and then fix the progesterones, and there's like a seesaw, the testosterone will go down, the testosterone and the androgens will go down. So there's a lot of beautiful biochemical intricacies that, you know, and interrelationships that you have to be aware of and understand that the blood test is not going to tell you the story. Bioidentical hormone replacement therapy prescribing is an art that you develop. DEXA scan, of course, mammogram, urinalysis, you know, you should have all your, you know, baseline PAP and all that done before you start bioidentical hormone replacement therapy. These are things I'm sure that are pretty self-evident. In prescribing bioidentical hormone replacement therapy, there's many options. Like I said, there's transdermal versus sublingual. And, you know, if a woman is experiencing vaginal dryness, then we, you know, add on the estriol intravaginal cream. There's also many interplays, and the time constraints are just too much to go over in detail. How beautifully you can, you know, sometimes combine, sometimes in certain cases, testosterone intravaginally, sometimes DHA intravaginally, sometimes the base has to be changed. Sometimes you can even help change the flora vaginally. These are all the art of prescribing bioidentical hormone replacement therapy that you can do to give the patient optimum benefits and effects. Same thing with progesterone, is pretty much sublingual, transdermal. I won't use hormones orally, and that is because I see too much, especially with the COVID situation and the vaccine situation. I started checking D-dimers. The D-dimers were elevated. They were borderline high to elevated on many of my clients. And when you start to give hormones orally, I don't know what their biochemistry or what their single nucleotide polymorphisms or SNPs are in terms of their liver detoxification pathways, in terms of their metabolization of the hormones. I don't know if I'm going to be activating clotting factors or angiotensin or so forth. I just don't do it. And 15 years of doing this or more, actually it's more, of doing this, I have, you know, it's been, I very rarely have had to go to oral hormones. So. I think let's touch on again on estrogen metabolism. There are good estrogens versus bad estrogens. So once again, not all estrogens. Horses mirror urine. Back in the day, Premarin. Why was that stopped? Okay, if the body was so adept at taking any kind of estrogen and metabolizing estradiol, then why did we have the Premarin stopped? Because the increased risks. No, there's a concept called good and bad estrogens. There are downline estrogens, 4-hydroxyestrones. Key pivotal points are if you hydroxylate and methylate, you might end up with a 16-hydroxyestrone, and which needs to be metabolized into, you know, maybe 4 methoxys that can be easily eliminated, provided that we have good gut, functioning, glucuronidation system is functioning, and so forth. So just understand, without getting too detailed, is that there are good and bad estrogens downline, and we don't check for that. So sometimes consider testing then for 2-methoxy over the 16-alpha-hydroxy ratio. There is enhanced hydroxylation methylation reactions in the liver of estrogens, which is very beneficial. You know, there are certain nutrients that can help with all of that. And nutrigenomic substances there's a substance, you know, DIM versus indole 3-carbinol. And again, without going into too detailed, I prefer to use a combination, because if you just use DIM, you eliminate 2 of the metabolites of indole 3-carbinol that can actually promote apoptosis of cancer cells and abnormal cells. So once again, there's a particular ratio, and I use, this is over the years of just studying this. National Institute of Health actually has studied indole 3-carbinol, so I use a combo DIM and indole 3-carbinol to help with the metabolism, at least at the phase 1, which would be the CYB1 enzyme, to help promote hydroxylation of the estrogens. Again, impaired methylation is key. I've explained to you that impaired methylation is folic acid cannot be metabolized. The MTHFR, which is the methyl-tetrahydrofolic acid reductase enzyme, cannot, is not functioning properly. So you cannot utilize the bioavailable thing that you need, the breakdown product folic acid, which is 5-methyl tetrahydrofolic acid. And if you look at all these Merck companies, they're promoting Deplin for the use of depression because, you know, methylation is required for fertility purposes. You need to have adequate methylation for heart health. You need to have adequate methylation for the serotonin and depression risks. You need to have adequate methylation for, you know, nerve functioning, neuropathies. Adequate, and 300,000 to 400,000 reactions in your body depend on methylation for detoxification. So I think it's so important to at least recognize when we're giving bioidentical hormone replacement therapy to at least check for that. So there's other key nutrients. Again, I do a whole presentation on that. So there's one here, it just again says there's 2 major pathways for estrogen. One is, I explained to you about the estrogen metabolism, but the other one is really interesting, is the induction of specific genes in response to estrogen receptor activation. So we certain ligands that are actually specific for estrogen receptor alpha and estrogen receptor beta. Now, what do you think is going to be more safer? If you have an estrogen ligand that's going to be more receptive and have affinity to away from the nucleus, that would be the beta, and over the alpha receptors. And that's why when you give too much estrogens, and that's why even bioidentical hormone replacement therapy, I get so many clients that are bleeding, they're having so many issues, and yet the person's doing the blood work and it's reading low, 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 but these women are really being over estrogenized. And it has to do with this concept of this estrogen receptor activation. If you flood her receptors with alpha activation, and on top of that, it's going to start spilling over and then start binding onto the beta, adding on then anything else like another xenoestrogen is just going to be not a good thing. You really increase a lot of estrogen, in the body. So understand the concept about 2 different kinds. One is estrogen metabolism, and one is this, estrogen receptor induction, alpha receptor and beta receptors. So again, I kind of already went over this, that the hepatic detoxification in terms of estrogen metabolism, you need to have a phase 1. So phase 1, pathway in terms of, specifically in terms of estrogen metabolism, you need to, phase 1 helps hydroxylate, in particular the CYB1 enzyme. Phase 2 is really the catecholamine methyltransferase enzyme, the COMT, and that's phase 2, that helps methylate the estrogens. And then we get also into the second pathway, which is more of the estrogen receptor beta and alpha. And this simply just tells you that estradiol can actually activate JNK via membrane-bound beta receptor, but it inhibits this kinase via the ER alpha. And JNK is responsible for pro-apoptic induction. What this means, this slide means, is that if you get too much estradiol, you can actually inhibit the very thing that's responsible for pro-apoptic induction of abnormal cells. So again, this is another, some nutrigenomic factors, indole-3-carbinol, how they can actually regulate at that nutrigenomic level in terms of, they actually help regulate even at the receptor level, which is very interesting, and the metabolism level. That's why I love indole-3-carbinol. These are other nutrigenomic factors that can help. So very often I use nutrigenomic enhancement. In fact, I've done a talk called, it's a long topic, it's called Nutrigenomic Enhancement of Low Dose Physiological Bioidentical Hormone Replacement Therapy. That's what it is in a nutshell. And you don't cause any harm that way. The downside would be, okay, the client's telling you it's not working. That's because you're missing something else on their biochemistry. You don't have to go high dosing. You don't have to use a Wiley method. You don't have to have a woman having her period. I think that's, in my opinion, that's not safe way to be doing bioidentical hormone replacement therapy. So these are nutrigenomic factors: ECGC, vitamin D3, ellagic acid, how they can act and help. We have many others that over the years that I've come to love. Again, it depends on the preparation, the kind, the bioavailability, but I just mentioned it briefly. And so I think nutrigenomics should be integrated with an approach in using BioHRT. I think that makes it a very safe approach. And again, just telling you about there's different estrogens, and there's in the downline aspect. Nutrigenomic optimization of BioHRTs. The pathways for both estrogen metabolism and receptor induction can be directed towards healthy responses by nutrigenomic compounds. And further, nutrigenomic compounds such as indole 3-carbinol participate in healthy shunting in both the metabolic and receptor pathways. Such compounds could effectively limit the negative effects associated with estrogen therapy. I use that as my added insurance. Again, I want to touch now, I want to kind of wind up and really tell you lab testing is everything. You think that just by testing one lab test that you're going to get the entire story. That's not the correct thinking, because I have even had people test their hormone levels for just testosterone. I've had males check testosterone 3 days in a row, same lab, going in the morning, and I've had levels from 55 to 800. Explain that. And we're going to make decisions based on just that one test result. I prefer, so these are some general facts. Hormone general facts is pulsatile. So you're going to vary during the day, varying, half-lives, time of the application of topically applied hormones. There are more than 20 circulating estrogens. Blood tests are not always accurate. And there's different, I prefer saliva, but in saliva, there's different methodology. There is the ELISA test, there's a radioimmunoassay, there's the liquid chromatography, mass spectrometry methodology. And that everyone has their own, I think it's just getting used to their own way of interpreting combined with the clinical results. Isn't it any wonder whenever you do a saliva test, why the labs always ask for the patient history? If they were so beautifully clear in interpreting their results, then why would they always ask for the patient history so much? I think the drug companies tend to use mass spectrometry, liquid chromatography to identify every drug, every hormone. And I prefer that methodology. I think that it separates the hormones. Identifying each hormone's mass weight is very important. So, I think it is definitely a little bit more costly. It requires specialized equipment. I think 24-hour urine testing is also amazing. And it reflects the hormone levels over a 24-hour period. But I think it depends on when you're doing the 24-hour urine testing, are you using the mass spectrometry method like the drug companies might use, or LSMS, or what other methodology are you using? So I think 24-hour urine can be very beneficial because you get so many more downline estrogens and so forth, but it's very impractical. Most of my clients are not going to pee in a jug for 24 hours. So I therefore, I go back and forth. If I really am worried about a woman's and her metabolization, I might say, look, after I do this saliva, after I do the blood, I'll do the urine as well. There's no harm in getting extra data points to help make you, give you a correct decision. So I think any lab test for hormones misses a big part of the picture, that the hormone functions requires the hormone, the nutrients to activate the hormone, a functional receptor, which declines with age. And so the measure for dosing is clinical, because you really end up with the hormones are a receptor response. Parkinson's is a down regulation and dysregulation of dopamine receptors. So many other things it's all about receptor. How are you going to have adequate levels of hormones, but what if the functional receptor response is not there? And that's why in my practice, I can only share my experience with you, is that please be careful of overdosing with estrogen. I've seen so much of it. And the critique always comes that, oh, well, if you don't give enough estrogen, then, the woman is going to get, osteoporotic. Well, how about testosterone? How about testosterone and bone density? It's amazing. 2/3 of your heart receptors have testosterone. There's so many bone receptors with testosterone. So I think, bringing that into the mix is a very, very, good thing. And again, I'm going to end the whole discussion with this treatment goal of BioHRT: minimize dosage of bioidentical hormone replacement therapy, by optimizing the estrogen metabolism, balancing any existing imbalances in terms of a functional medicine approach. Again, I listed everything down there. I already repeated it. Please don't forget this slide, because this, in my practice, when I balance everything and I look at it like as a multifunctional approach, we can rock it. And when we don't do that, we depend on one vertical, I think that's when issues occur. So I'm open to any questions.
Dr. Naina, thank you for an excellent presentation on the safety of bioidentical hormones. We actually do have a question in the chat from an attendee.
Yes.
The question is, what is your typical E3 dose for hot flashes and vaginal dryness in a breast cancer survivor?
Okay, in a breast cancer survivor, I will go and first get the blessing of the oncologist in being able to prescribe certain, it depends on the, you know, the whole, the type of breast cancer and so forth. But if I get the blessing of the oncologist that I am able to prescribe estriol, I will then start to prescribe testosterone and minimize my prescribing of the estriol by maximizing the testosterone, which I know I'm getting some aromatization from. So typically, you know, maybe up to, I'll go up to a dose of 2 milligrams, and I may even use a combination of very low dose estriol, 0.5, rather than 1 milligrams per ml. And then you typically use estriol intravaginal cream, 1 milligram per ml, and you use 1/2 to 1 ml, you know, every day till till her vaginal dryness is resolved. I'll actually go ahead and I'll use estriol at 0.5 mg per ml, and I'll give 0.5 ml, but I'll combine it with testosterone. And I'll try to increase the testosterone to where she feels, you know, and DHEA. I have DHEA ovules as well. So it depends on the client, but in a breast cancer survivor, in a nutshell, maximize the testosterone, maximize the DHEA, and still minimize the estriol.
Perfect. Thank you, Dr. Naina. Hopefully that was able to answer the question that we had. And thank you again, like I mentioned earlier, for an excellent presentation. Any other questions in the chat? All right, no other questions. I guess that will conclude the Access Live webinar. Thank you all. The recording will be available to you on our YouTube channel. Enjoy your night.
Bye-bye, everyone.